Good morning, everyone. My name is Dr. Celia Cully, and I'm a clinical pharmacist at Royal Jubilee Hospital in Victoria, BC. And I'll be presenting today with Dr. Val Stoyanova, internal medicine physician here at Island Health. We'll be presenting on the Critical Air Project, Climate Conscious Inpatient Inhaler Practices, which is a collaboration between Island Health, Cascades, and Environment and Climate Change Canada. Next slide. We have no industry-related financial disclosures, although we have received a small stipend from Cascades, which is a not-for-profit organization, as mentioned, funded by Environment and Climate Change Canada. And we have received a National Innovation Grant through Cascades, as well as a local grant funded by the South Island Facilities Engagement Initiative.
So, which brings us to the first part, which is the why. We're not going to go into too much detail because the audience here does know a fair bit. We're going to cover some of the basics because we don't know who's going to be listening to this recording later. We know that healthcare can be quite carbon intensive. On one hand, we see all the downstream complications of climate change. We admit patients with COPD and asthma exacerbations with each forest fire season, but on the other hand, delivering healthcare can be quite carbon intensive. We know that 4.6% of Canada's greenhouse gas emissions are related directly to healthcare delivery, which is on par with the aviation industry. The single largest carbon expenditure category within this is related to medication use. And within medications, metered-dose inhalers do deserve special mention. We know that depending on the source read, a metered-dose inhaler can have a greenhouse gas carbon footprint of up to 139 kilometers by car. Initiatives are underway in Canada and abroad, including Cascades initiatives to decrease the carbon footprint of outpatient prescribing the primary care setting, but little is known up until now about the processes that can lower inpatient inhaler-related greenhouse gas emissions. Celia and I are based out of Victoria, BC. Island Health is over on the west coast. We serve a population about 860,000 across 115 acute care sites, and each month Island Health dispenses just over 2,900 inhalers, which is about 50 tons of CO2, or equivalent to driving around the circumference of the Earth 4.5 times each month.
So we identified that there was a huge opportunity to improve our practices, but before we could get going on some quality improvement, we really had to set the groundwork. And there's some very important foundational steps that we identified that we want to share with you as you consider embarking on these types of projects. So the steps I'll go into, first of all, relate to developing partnerships. So this is a critical stage, and we do encourage anyone embarking on this work to review your organization's strategic framework or strategic plan and identify if climate change is a part of that plan. Once you've determined if it is included, repeat it consistently as you engage with different stakeholders. If it's not part of the plan, you might need to look at other levels of government who certainly have prioritized climate change as it relates to health. In terms of identifying allies, we learned quickly there were so many people we needed to engage, and we wanted to engage them early, whether that was different clinicians, different people working in waste management, help with policies and procedures, housekeeping, porter services. There are just so many people in complex, large organizations, and we don't want to exclude people. So just starting by socializing the idea and getting to know people around the organization will be hugely foundational as you get going in this work.
Part of our relationship, we're used to develop an inhaler life cycle analysis in hospital. So we've established the pattern of practice and what an inhaler does and the journey of an inhaler in the hospital setting by speaking with a number of stakeholders, RTs, nurses, porter services, trainees, physicians, pharmacists. It was quite an extensive part of the project. We know that an inhaler typically gets prescribed for the first time in hospital in one of 3 settings. Sometimes a patient comes into the emergency department with respiratory difficulty, in which case an inhaler is prescribed. Alternatively, the patient comes in for a non-respiratory issue, and we've identified that they're on an inhaler at home, in which case their home inhalers are prescribed. Or lastly, a patient comes in for an elective admission, for instance, a planned orthopedic surgery, and the best possible medication history still reveals an inhaler, which is then prescribed. Once the patient is up on the ward and a need for an inhaler is identified because it's regularly scheduled or because they have shortness of breath, we can go into one of three scenarios. The first one, A, the patient has an inhaler at the bedside, in which case there's no problem, they use it. In situation B, although the patient has an inhaler at the bedside, it's not immediately available. This can be a situation, for instance, it's hidden under a newspaper, it's hidden in their toiletry bag, the patient put it in a drawer, in which case, especially if it's a critical situation, a new inhaler has to get dispensed. And this either comes from pharmacy or from ward stock, at which point the patient can use the inhaler. The third situation is when the patient does not have an inhaler ordered, in which case a new order is written, at which point the inhaler can be dispensed either from ward stock or from the hospital pharmacy. If the patient has an inhaler, but the inhaler order is changed, the existing inhaler is discarded and a new inhaler is dispensed. This is true even if it's a dose change. For instance, if you have fluticasone 125 BID and you increase the fluticasone 250 BID, the original fluticasone inhaler will be discarded and a new inhaler will be dispensed, even though the higher dose can be achieved with the same inhaler. And this is largely related to policies about labeling inhalers appropriately. When an inhaler order gets processed in pharmacy, it can either be dispensed as is or changed to an inhaler that is currently on formulary. And by the time of patient discharge, the inhaler is typically discarded. So the patient, having the inhaler, has to throw it in the trash and then get a new prescription, cross the street, go to an outpatient pharmacy and purchase an identical inhaler to the one that was just thrown out. Needless to say, this is problematic. In order for us to quantify the problem, we looked at a number of change management metrics. We were able to work closely with our pharmacy informatics team to get inhaler prescribing data, inhaler dispensing data. A number of inhalers also come out of the hospital ward stock, and those aren't easy to quantify because there's a huge heterogeneity in the different cabinets. There's the simple lock-in key cupboard cabinet, there's Omnicell cabinets. So we use ward stock transfers, meaning how many inhalers get used to replenish the ward stock as a surrogate marker for use. And lastly, we did very high level data of how many inhalers are purchased annually in our healthcare authority.
As we work through obtaining these metrics, and as mentioned, pharmacy informatics was a huge ally to help this work, as well as our provincial procurement agency in terms of the purchasing data. We started to determine that although we have these numbers of inhalers, we wanted to switch over the equivalent amount of carbon per inhaler and then on a health authority level. And we found that one of the metrics that seemed to make a lot of sense for people is when we converted the amount of carbon emissions to how many kilometers by a standard gas-powered car, so equivalent kilometers by car. And then because the magnitude is so large, equivalent Earth circumferences can be quite eye-catching when we think about how many times we're driving around the Earth by gas-powered car per month, for instance. And then in terms of cost, these are generally confidential numbers. There's the list price for inhalers, but also the confidential contract prices. So those are generally internal numbers that aren't able to be shared more widely. This is a fantastic resource that Val has put together that I supported, but it really highlights the different products that are available, the cost, the list prices are here, and then coverage for outpatients. But then as you can see on the right-hand side, the kilometers by car per inhaler. In terms of another kind of foundational step before we got going is we started to realize pretty quickly that in order to engage people, in order to do things right, in order to gather these metrics, these things take time. And it was really helpful for us to kind of manage our expectations and acknowledge that this is going to take time. But when we have, when we're going to make these meso and macro changes, that it's going to have a huge payoff, but kind of managing those expectations was a key thing for us. In terms of our three-pronged approach, we quickly realized that our change ideas fell into three separate categories: policy changes, operational changes, and our educational campaign. Our first kind of key area was looking at policy changes, and we identified that there were opportunities to optimize our hospital formulary, assess the HFA content in our meter dose inhalers, so how much of that hydrofluoroalkane were actually in our individual contracted inhalers, and then lastly, looking at a multi-dose medication on discharge policy. So what are we doing when patients are being sent home? So the first one was our changes to our hospital formulary. As some of you may know, there are kind of two different formularies in the Canadian healthcare setting. There's the outpatient formulary and then the inpatient formulary. There are over 35 different inhalers available in Canada. Many of them, not all, but many of them are available through different means through our outpatient formulary. But in hospital settings, there's often a somewhat more limited number of inhalers available. And this is kind of our armamentarium for ordering and dispensing in the hospital setting. So understanding which inhalers were part of our provincial hospital formulary was a critical and foundational step to better understand what are the tools in our tool belt and what are the relative carbon emissions for the different products. Are there opportunities to change our inhaler on formulary, and what are the processes to do so? So one of our initial first steps was liaising with really key pharmacists in medication use management and formulary decision-making. And we quickly realized that our dry powder inhaler for our SABA category was a salbutamol discus, which actually wasn't available as a benefit for outpatients. So we learned that maybe there was an opportunity to add a different dry powder SABA to our formulary. And by considering the carbon footprint, the cost, the coverage, how could we make a case for adding this to our formulary in a way that followed the correct processes? And I do encourage you to reach out to your medication use management team to identify steps that are specific to your area of practice.
The second policy change we worked on is assessing the HFA content of different types of inhalers. We know that the carbon footprint of any meter dose inhaler is going to vary significantly with not just the type of propellant, but also the volume of propellant within the device, even within the same pharmacologic category. So we know that inhalers that are low volume HFA, such as salbutamol, there's two different low volume providers in Canada, have a carbon footprint about 38.8 kilometers, whereas the high volume equivalent has a carbon footprint of 112.6. These inhalers are otherwise identical for all intents and purposes, meaning they have the same indications and contraindications and the same techniques. The only difference is the overwhelming carbon footprint. Incidentally, we happened to find out through our contacts at HealthPro that the provincial contract for salbutamol in hospital was up for renegotiation last January, at which point we conduct environmental impact analysis. We realized that Island Health and the entire province currently contracted with a low volume HFA provider. So we calculated, based on the number of inhalers used, what the change in carbon would mean. If we were to change to a high volume HFA, that would be a 290% relative increase in the carbon footprint. And for Island Health alone, this would be about half of our entire health authority-wide vehicle fleet. We wrote up our proposal, and then we met with pharmacy leadership, and we also spoke with one representative of the provincial procurement body. At this point, the report got fairly widely disseminated to pharmacy leadership and other BC health authorities. And the contract remained with a low volume HFA provider, which saved 1,846 tons of CO2 per year, which is equivalent to driving 6.4 million kilometers in a standard gasoline powered vehicle. And lastly, our last policy change was looking at multi-dose medication on discharge and creating a hospital-wide policy. We know that the standard of care in the hospital system is a unit dose system. This means that a single dose is going to be dispensed for the patient in a 24-hour period. However, we know that this doesn't really apply to inhalers, where a single device or inhaler uses up to 200 doses. If you calculate the average length of stay in Canada, which was just over 7 days for 2022, we know that by the time someone in discharge, there's a huge number of doses left within each individual device. We know that for salbutamol, up to 90% of doses are wasted per inhaler. We also know that inhalers cannot be repurposed for a different patient once the patient leaves hospital, largely due to cross-contamination issues. This unfortunately means that usable medication is going to be discarded. This has a number of unintended consequences, including significantly increasing the carbon footprint, causing a financial burden to the patient. And some of these inhalers are very expensive, and it creates financial hardship for the patient to have to go and purchase a new inhaler when a perfectly good inhaler that is nearly full was chucked in the trash. Lastly, there's significant financial implications to the health authority as well, because disposing of inhalers costs money. So we set out to develop a policy and accompanying procedure document to facilitate having patients take remaining doses of inhalers with them. This is a very long-term project. I'd say we're only about a third of the way there. If you were to embark on this, if your hospital does not already have a policy, I do recommend budgeting 18 to 24 months for this change idea. It is very labor intensive because it requires a rollout at a systemic level, but it is very impactful. Widespread stakeholder engagement is going to be necessary, as we've already discussed earlier.
Our next area for making our changes were the operational changes. So there was a few change ideas in this category as well. The first one was changing the location of the tamper seal. So when we were starting to look at the process mapping, we discovered that there were two different locations within Island Health where the tamper seal was placed on individual meter dose inhalers. On the left-hand side, you can see that some sites are using the tamper seal directly on the inhaler, covering the cap. At other sites, the inhaler is placed in a plastic bag and the tamper seal is placed over the edge at the top of that Ziploc bag. When we did our process mapping, we discovered that the plastic bag doesn't fit very well into the medication cabinet. And so what we found is that nurses were routinely removing the inhaler from the bag as soon as it arrived on the ward, regardless of whether the patient needed it or not. By damaging that tamper seal automatically, kind of regardless of the patient needing it, it was ultimately going to be disposed of because there was no way to tell if the inhaler was used or not. Alternatively, next slide, by keeping the tamper seal located across the cap, when it arrived to the unit, it fits quite nicely into the medication drawer. And then if a patient needs the inhaler, the tamper seal will be broken when the cap is removed. If the inhaler is never used for that patient, the tamper seal will remain intact and it can be repurposed for a different patient because it was never contaminated. So through this work, we identified that if we could change the location to the cap at all of our sites, this would be a relatively low-hanging fruit, we thought, to help reduce waste. We are very close to implementing this, but of course we need to engage pharmacy operations who actually place this seal and nursing to ensure that they are returning inhalers to the pharmacy for tamper seal inspection prior to being repurposed. The next operational change relates to changing ward stock inhaler content. Next slide. Ward stock medications are generally stored in patient care areas so that they can be readily available for urgent situations. We don't want, if a patient is acutely short of breath, we don't want that patient having to wait long periods of time before an inhaler is sent up from the pharmacy, which is often in the basement of hospitals, up to an acute patient ward. So in general, urgent medications are located on the ward, in the ward stock, so that they can be needed quickly. Used quickly. Maintenance inhalers, however, are never needed on an emergency basis. And so there may be an opportunity to remove maintenance inhalers from the ward stock to reduce waste. We did find that ward stock inhalers are not routinely labeled with patient-specific labels. So when they're removed from the ward stock, if they don't get a label put on them immediately and they're placed down on a table or surface somewhere, for instance, it may be quickly difficult to determine which patient that inhaler belonged to, therefore it will be disposed of. And this can mean that multiple duplicate inhalers are dispensed for patients, which can lead to significant waste. So although we are still working on this in our local health authority, we have been reviewing which inhalers are on ward stock and where there might be opportunities for improvement. But we did learn from our colleagues in Fraser Health, and a shout out to Erin Chijani and the team at Fraser Health for sharing this data, that at a small hospital of just over 100 beds over 6 months, over 100 inhalers were saved at a cost of over $4,000 and 2,000 kilograms of carbon emissions. And so when we think about how this could be rolled out on a wider basis, there are substantial potential gains.
Lastly, we set about redesigning the clinical order sets now that we have low volume HFAs and also low carbon footprint DPIs on formulary. Clinical order sets are a curated set of orders that are typically tick boxes that include best practice alternatives. They do not contain every option, but they are curated to guide the prescriber into choosing something. For instance, in many infectious preprinted order sets, we know that antimicrobial stewardship is incorporated that limits the available options for the different types of antimicrobials in an evidence-based manner. So we set out to incorporate a climate stewardship akin to the antimicrobial stewardship. This is the original order set. You can see that all the inhalers were listed out without any sorting or any significant carbon footprint description. Once we redesigned the order set, there was an explanatory paragraph that is now hyperlinked to some evidence that the clinician can click on. And we review over here the carbon content of every inhaler. Additional ideas we had include adding a green leaf next to environmentally friendly options, and we're still working on that, or alternatively having the low carbon inhalers be a click, whereas having the high volume or high carbon inhalers be manually written or manually typed out. So we use laziness in our favor.
The last approach, part of this quite large quality improvement project, was our educational campaign. As you can see, we were rolling out a number of change ideas or working on them, and we needed to include the many different stakeholders that are involved in patient care and workflow. So although we're still ongoing with this educational campaign, you can see many different clinicians and team members that need to be included as we roll out education. Next slide. So part of this educational campaign include one-page infographic posters, and we created infographics for different clinician groups. So this, as an example, is our pharmacist infographic. However, we have a number of infographics for different provider groups. And basically listed in key issues related to this topic, and then highlighting some change ideas that different clinician groups could enact in their practice starting today. In terms of having to have that seamless care with outpatient prescribers, we did want to include a letter to primary care providers about if there was an intentional change to a patient's inhalers while they were admitted to hospital, so that they weren't inadvertently changed back, thinking that maybe this was some sort of auto substitution in the hospital, but in fact sharing with them that these were intentional changes that were discussed with the patient. And lastly, we also included a trainee video that's meant to connect with our medical students and residents going through our clinical teaching unit. This is also accessible to other learners who might be interested in this topic, to highlight some ideas that they could incorporate in their practice, as well as providing some of these foundational components to why this is important.
So to summarize, over the last year, we've engaged stakeholders in multiple levels. Using these relationships and leveraging our relationships, we were able to develop an inhaler life cycle analysis that we then used to develop policy changes, operational changes, and a widespread education campaign in an effort to decrease our inpatient inhaler-related carbon footprint, decrease hospital costs, and maintain equivalent or better patient outcomes. So thank you so much for attending. It was our pleasure to be able to present some of this data today. Please keep an eye out for the Critical Air Project Playbook that is coming out on April 1st, and check out cascadescan.ca for excellent resources. Thank you. We'll take questions.
So I'm just going through the chat right now, and we've had a number of excellent questions coming in from the group participating today. The first one, Val, maybe I'll direct towards you. What is low volume versus high volume HFA? Could you just go over that again, the differences between them?
Thank you for asking. So low volume HFA, HFA is the propellant within the inhaler. Some types of inhalers use ethanol as a solvent, which spares the volume of HFA within the inhaler. So we know that depending on the content of a propellant, the carbon footprint will be different. For salbutamol, we have 2 low-volume providers, and we have 3 high-volume providers currently available in Canada. The high-volume providers have a carbon footprint of about 112 to 113 kilometers. The low-volume providers are closer to 39 kilometers by car. Is that helpful?
I think there was a follow-up question related to, are there different inhalers with a different number of doses? So are there kind of small inhalers with 50 doses versus 200 doses, for instance?
Some of the dry powder inhalers do have smaller volumes, but most of the meter dose inhalers don't. So even the low volume HFA inhalers will have 200 doses for salbutamol. So it's not a dose issue, it's a volume of propellant issue.
Thanks, Val. Another question we have here is, how were the provider letters disseminated to the primary care providers? And was that with the discharge papers at the time of discharge? I can speak to that. So also, we didn't include it, but another one of our resources was a supplement for our community pharmacists so that they're also aware of whether these were intentional changes or not, because we do want to allow for consistent messaging between our inpatient and our outpatient care teams. So this is a change idea that we are still rolling out at this time, but our current plan is to include the letter with the discharge summary. And in the case of the community pharmacist, it would be attached to the discharge prescription so that it's clear to our outpatient colleagues that these were intentional changes and who was involved in the those decisions, which included the patient. Because we do want to highlight shared decision making, and these resources reflect that. So that's kind of the plan for how they'll be rolled out. But we are in the process of providing that education, and we'll hope to be rolling that out in the next few months. Any other questions? So I see a question here. Where should people start if they want to work on this? So, well, first of all, you've seen this webinar, so it provides a great overview. And as Val mentioned, we worked on, in collaboration with Cascades and Environment and Climate Change Canada, a playbook. So on the Cascades website, which is cascadescanada.ca, there's already the primary care playbook for sustainable inhaler practices. And as of April 2023, we'll also have a playbook related to inpatient practices to support this work that highlights these different change ideas, provides more details, and will help support you to hit the ground running, because as you can see, this was a lot of work that we've been putting in for the last year or so. And we want to help streamline the process. So please check out that playbook to help streamline your processes, and you can get going sooner rather than later. I'm seeing a hand. Yeah. Hi, Valerie.
Hi. So I'm Brenda, and I both work at Unity Health in Toronto. I'm a general internist there. And first of all, you guys have done outstanding work, and thank you for doing that. My question is a very practical one, because change management is hard. Like, how many people and how long did it take, and how much of that will the playbook save? You may not have those metrics, but if you do, I'm just kind of trying to work through what you've described in our own setting, and I just kind of I need a sense of the human resources involved.
Yeah, so I'll be honest, a lot of this was our dynamic duo spearheading the process. So Celia and I put in a lot of hours, but a lot of it was upfront time management, creating those bonds, getting the project off the ground, and developing your life cycle or process mapping of what happens to an inhaler. So that can hopefully spare you a bit of time since we've done some of the groundwork there. Otherwise, it was a very widespread team in terms of who had input. And I'd say the core group that developed these resources and work on implementation was probably about, 10. Is that what you would say, C?
Mm-hmm. Yeah.
And then how did you find the attitudes or kind of towards change of different levels of the healthcare system?
We were pleasantly surprised. In some circumstances, talking about a carbon footprint reduction isn't necessarily as exciting. However, when you frame it in terms of cost savings or improved patient outcomes, people are very excited to listen. And if you also happen to sweeten the deal by showing, 6.5 million kilometers by car could be saved per year, this is very motivating to people. We've had extremely excellent engagement from everybody from Porter Services through to students, the entire pharmacy department, and high levels of Island Health leadership as well have all been overwhelmingly supportive. Overwhelmingly.
And just to add to that, as I mentioned in setting the groundwork, is reviewing your organization's strategic framework. And if that is already included in there, so within Island Health, there is a commitment to reduce greenhouse gas emissions. And so this kind of project directly ties into the Island Health strategic framework. And then early on in this project, we reached out to one of our quality councils. I don't know exactly the governance structure at Unity Health, but kind of determining if there's a quality council that this might fit under, and then bringing it to them early, highlighting the value, the triple win in terms of reducing costs, climate benefits, and improvement to patient care. And we, by being endorsed by Quality Council early in this process, we were able to leverage that when we were going to other stakeholders, say, hey, this has been endorsed. We'd like to, can we have your support? And that's been really helpful to kind of move through the system and connect with different people early.
Would you say that Quality Council now considers climate change improvement part of one of their quality metrics?
Yeah, when we mentioned the Island Health Strategic Framework, I think that was something that was really helpful for them to get on board early. And then when we mentioned, kind of when Val walked through the process mapping to that team as well, highlighting the amount of waste, I think there's a big push, like how can we have lean processes and reduce waste, because that will equate to cost savings, even though individual MDIs in general aren't that expensive. When we're talking inhalers in the thousands or tens of thousands, it does add up. And so how can we save the system money as well? So really focusing on that triple win, I think can be another approach to, as you early on get engagement from the governance structure at your specific site or health authority.
Thank you.
I'm seeing a question in the chart from Aaron. Has there been interest on revising these orders when we move or have moved to CPOE? So there has, and we kind of took advantage of that because we're currently in the process of moving to virtual order entry. So we incorporated the planetary health lens to the virtual order entry, which will be rolled out island-wide.
Yeah, it actually worked on the scale of things relatively well, the timing. So there was a big movement to review order sets island-wide. So Val and I were fortunate that that process was already happening. So we were able to just jump in, and we had really great support from the order set team and the lead respirologist on that order set review, and the pharmacist involved in that as well. There's another question about educating community pharmacies about the carbon footprint of inhalers, as many do not know this. And I completely agree that we're still working on awareness of this issue across disciplines. So when we speak with pharmacists, pharmacy technicians, nurses, physicians, et cetera, nurse practitioners, the list goes on, respiratory therapists, like I didn't even know about this issue until a few years ago myself. And I think there are so many that still don't know. And that's part of this work is, and to have that consistent messaging, ensuring that we're liaising with the different outpatient providers as well as the education for the inpatient providers to highlight this issue, why are we doing this? And that was one of our goals of our different one-page infographics. We know people are busy. We don't want to be, condescending or patronizing, but how do we share this information so that we can get the word out widely? And we hope that our infographics, as well as those one-pagers to our outpatient community pharmacies and our outpatient providers, to highlight why we're doing this work, why we made a switch, or they're just, maybe there's no switch, but we reviewed inhaler technique while they're admitted, or different ways that we can optimize use of inhalers if it's not appropriate to switch, because we know some patients it's not going to be appropriate to make switches, but how do we reduce waste? How do we optimize medications for our patients? So it's not just about switching.
Thank you. I think we ran out of questions. Any closing comments, C?
No, just thank you so much for your interest. And I think Val mentioned already, we're keen to hear from you. If you please check out our playbook, and our contact information should be there to help spread this work across the country, because we're really hoping that this work can be spread more widely, because there is such a huge value.
And please don't be shy to reach out. We love hearing from you.
Thanks, everyone.
Thank you.